I'm Henrik Malchau from Boston and Gothenburg. I work both places now. Disclosures here are not relevant for this presentation. I want to acknowledge the co-workers in the NARA group, the Nordic Arthroplasty Registry Association, because I'm going to use data from their study to try to answer the question. How do you answer that question? Meaning, the infection guys, they collected 400 people from all over the world, and they're voting now which is the best. 83% agree that's the way to go. We can do the same for cement fixation. Yes or no? We can vote at the end of this presentation. Otherwise, what you need to do is the best possible evidence. And the only way to create that is really to do randomized trials. Surgical research or comic opera, many questions, but few answers. Let's start cutting and then see what happens. And that's probably been the attitude for many, many years. So why don't we do randomized clinical trials? Because it's difficult or very close to impossible if you're going to look on 10, 15-year outcome of a total hip procedure. And what has replaced the randomized clinical trial is the prospective observational study, where now 10 registries, 10 countries worldwide have really good coverage of registries. And that's what I'm going to use in order to try to answer this question. In British Medical Journal, April 2014, you can find this paper, Failure Rate of Cemented and Uncemented Total Hip Replacement, Registry Study of Combined Nordic Databases. That's the NARA group. And in this paper, we use information from 347,000 total hip surgeries. The objective is to assess failure rate of cemented, uncemented, hybrid and reverse hybrid total hip replacement in patient age 55 or older. And I would actually focus on the oldest group here, 70 and older, and based on the NARA database. It's, as Johan mentioned in the first talk in the last session, it's been a substantial amount of work to harmonize the databases in the 4 Nordic countries. We are finally there now, and there will be a wealth of paper coming out of this cooperation. These are the yearly number of total hips by fixation. You can see the non-colored bars are cemented, and that's decreasing, and the green bars are increasing, that's uncemented. So there is an ongoing process where cement gets less used and uncemented more used. There's actually differences within the 4 countries, where I usually say that the Danes and the Finns are the cowboys in the Nordic countries. They have really very rapidly switched from cement to cementless fixation. Sweden, as you can see in the lower right, has stayed most conservative and are still around 80% all cemented implants. What are now the outcome of these 380,000 patients here? This is Kaplan-Meier survival. You can see the brown top curve, that's all cemented. The next red is hybrid, and then you have the green uncemented. So that speaks for itself, more or less. There is a difference if you look at the 15-year outcome here. If you take all ages, this is from the 500,000 database, there's the same difference. And one of the interesting points is that the drop, you have a sharp drop here for cementless, and probably related to difficulties obtaining a good femoral fixation, and specifically in the elderly patients. Okay, that's 4 registries. We can widen this and look more global on the thing. And we have now access to 1.3 million total hips in 7 countries. And what we did here was an age stratified risk estimate. This paper was published last year in Core. Age stratified risk estimate of revision with different fixation techniques and comparing cement versus uncement. If you look at the countries here we looked at, Canada is plus 80% uncemented. Denmark, and note the increase in the past 5-6 years in use of uncemented in Denmark. Australia, relative constant. They seem to have identified which patients benefit from cement, which doesn't. New Zealand, increasing. England, Wales, increasing. Shani will be spinning in his grave. Norway, slight increase. Sweden, the most conservative. Look at then the outcome here, and in one slide, where the revision risk cemented versus uncemented is compared here. If it's green, then cement has significant lower risk for revision than uncemented. And you can see that goes across those 4 countries, and that goes in patient age 60 or older. So the vast majority of your patients, according to these 1.3 million observations, is actually doing better by all cement. How has those 4 countries then responded? How much have they changed fixation? You can still see that Norway is increasing. They're actually all increasing, except Australia. That's relative constant. What are the benefits of introducing new hip prostheses and knee prostheses? This is from the Australian Registry. Of 33 new total hip implants, 23 had the same as the older existing system, as the gold standard. 10 was worse. Of 28 new total knee implant, 20 had the same result as the older system, 8 was worse. There was actually none better in the past years. I haven't discussed implant. I think there's a number of well-working cemented implant. What the important issue is how you do it. Successful cementing depends on a good interlock between the cement and the bone, trabecular bone. You need to do a pre-op plan for every case you're doing to understand what sizes I am facing here. The really small, narrow femurs will not tolerate cemented stems. Don't do this. You need to enter your femur in the right plane. And that's actually the fossa piriformis. Otherwise you will get something looking like this. Even if the frontal looks very nice, the lateral in this patient here have exactly that appearance, and you get motion between the cement, which means when you open up your canal, you quite often, almost always have to sacrifice the posterior wall. The most important specific step in doing a good cementing, having a good cementing technique, is use of pulsatile lavage. Plug your femur first. After that, use lavage. You need a specific tip in order to clean up the femur. And you need to have it clean, as you can see there. Clear fluid back, approximately 2 liters are needed. Here's a cadaver specimen with the same. Cool your cement so you have time enough to work with this. Vacuum mix it is the recommendation to get rid of stress risers. Apply then the proximal seal and wait until you have a sufficient Dowey state of your cement. You want the cement out in the trabecular bone. Finally, insert your stem. Not too fast. You can count 1001, 1002. It should take approximately 15 seconds. You can also count 1 beer, 1, 2 beer. That takes 1 second too. And then you should end up like that. All this has been evaluated and developed over the years through specific analysis in the Swedish Registry with Poisson advanced Cox regression model. And you could summarize the experience of cementing in Sweden by looking at these 80,000 patients, 20 years survival, 93.5%. All comers, all reasons for revision. So yes, in conclusion, the implant survival of cemented total hip replacement was higher than that of uncemented total hip in patient age 65 and over. The increased use of uncemented total hip in this age group is not supported by scientific data. So yes, cementing fixation is still the gold standard, but be aware of the cementing technique. We have a Registry meeting next year. You're welcome to Gothenburg in May. It's usually as good weather as here. Thank you.